Okay, I think we're going to get started. We still have people trickling in, but we're going to start this evening. So I want to first introduce myself. I'm Therese Gardier. I'm a nurse practitioner with the Department of Urology at Yale. I'm also the CME director for the department. And tonight it is my pleasure to introduce both Dr. Sprenkle and Leapman and thank them for joining us tonight to discuss prostate cancer. Dr. Preston Sprenkle completed his medical school at Columbia, his residency at New York Presbyterian, and his fellowship at Memorial Sloan Kettering Cancer Center in New York. He is Associate Professor of Urology here at Yale, Division Chief for the Division of Urology at the VA Connecticut Healthcare System, Director for the Urology Research Fellowship Program, Director for the Urologic Oncology Clinical Fellowship Program. Dr. Sprenkle has dedicated his career to using the latest imaging technologies to improve diagnoses. He is one of the first physicians nationwide to implement the use of the Artemis device and is a pioneer in focal therapy to treat prostate cancer. Dr. Michael Leapman is a urologic oncologist here at Yale. He is an assistant professor of urology at the Yale School of Medicine and clinical program lead for genitourinary cancers at Smilo. He attended medical school at the University of Maryland and completed his residency at Mount Sinai Hospital in New York. His fellowship in urologic oncology was completed at the University of California, San Francisco. His clinical and research interests focus on the diagnosis and treatment of prostate and urologic cancers. Thank you both for joining us tonight. We will do both lectures and then have a Q&A at the end. For any questions, please post them in the chat or Q&A box, and I will monitor through the evening. So thank you.
All right. Good afternoon, evening. So should I start and I'll share my screen?
Yes, I believe you can both share screen, right?
I will try it now.
Okay, well, here's hoping.
Let's see. Oh boy, hold on.
Don't worry, Eliza's still on.
So let me try this again. It's asking me which. Okay. I apologize, but it looks like I have a new computer and they have not approved me to share my Zoom screen, share my screen with Zoom.
Preston, do you want me to jump in while you work on that for a second?
Yeah, I need to probably get to a different computer. So maybe we'll do this kind of reverse order and
absolutely
even temporally, even though I truly apologize. But yeah, why don't you go ahead, Mike? I'm going to run over to my office where I have it loaded and hopefully I can share there.
No problem. It'll be a perfect, it'll build the anticipation for your talk, I think.
All right, sounds great.
All right, now hopefully I can share mine. All right, can everyone see my screen here?
Yes.
All right, so, well, good afternoon and good evening, everyone. It's really a pleasure to be here. Today I'm going to be talking about treatment options for localized prostate cancer. I have no disclosures other than I'm a urologist and I treat prostate cancer. And just a little bit about me, because we can't meet each other face to face, but I'm a urologic oncologist, which means I'm someone who treats prostate, bladder, kidney, and other urologic cancers. So that's really my clinical interest, and that also ties in with my research interest, which is really about understanding and improving exactly how patients navigate this initial decision-making process of whether or not they might have prostate cancer, what to do when that diagnosis comes in, and how best we should navigate that, both from a decision science perspective, as well as enhancing the technical science of how we perform treatments if necessary. So the overview for this afternoon is to talk about the landscape of treatment options. And first make the point that treatments really have to be customized to the individual patient. And I think that's really a necessary starting point for any discussion of prostate cancer treatment. We'll talk about some of the options in more specific details. The first being active surveillance, which is a period of close monitoring for prostate cancer, as well as radical prostatectomy surgery, radiation, touch on some exciting innovations in terms of focal therapy, and conclude by thinking about some thoughts about survivorship and how we follow patients after their treatment. So, a word about why treatment has to be customized is that, biologically, prostate cancer is highly heterogeneous. This figure depicts outcome trajectories in terms of the risk of recurrence for patients at the time of diagnosis, and they're stratified by their clinical parameters. And so the patients in the top blue line have low risk features or highly favorable features at the time of diagnosis, and the lines lower down are clinically more concerning at the time of diagnosis. And so that correlates very strongly with their risk of having a recurrence. So for people who are low risk, they are very likely to do well for years and years with or without treatment, but far different for people whose cancer is more aggressive. So based on that, a one-size-fits-all approach will not work for prostate cancer. And I think that's been applied largely in the past, but at Yale, I think we've really tremendously moved on, and every treatment is customized to the patient's biologic risk of their cancer, as well as their goals, perspectives, and overall medical health. So what do we mean by localized? What is localized prostate cancer? So those are cancers that are confined to the primary site, confined to the prostate itself. And that is actually the vast majority of cancers that are diagnosed. So about 3/4 of prostate cancers that are diagnosed in the United States every year are localized, with about 13% being regional, the rest being distant or metastatic. So the vast majority of, or the majority of prostate cancers that we find are fortunately localized to the prostate. And patients do really quite well with localized prostate cancer. 5-year relative survival, 100% for patients who have localized prostate cancer. And that speaks to the availability of highly effective treatments, and also the fact that we're finding these very early when they're largely incidentally detected and have symptoms and have not left the prostate. But that's really contrasted by how things look when patients have distant disease. And so the real reason behind treating is to avoid progression to distant disease, which is fatal. So treatment for patients who have low-risk cancers, those earlier ones that we spoke about that are less aggressive, has really changed dramatically in the past decade. So in 2010, the majority of patients who had a low-grade prostate cancer, and this is what we're talking about here, were getting treatment with either surgery or radiation therapy. And as of 2015, and the numbers are continuing to trend in this direction, the majority of patients who have a low-grade prostate cancer are not being treated, and they're being monitored with active surveillance or watchful waiting. And this is sort of long overdue and sort of an appropriate inversion in the trend. So what do we mean by active surveillance? Active surveillance is a protocol consisting of careful monitoring of prostate cancer with the intention of preserving the window for cure should aggressive disease later be found. And this is a strategy that is applied to patients who have low-risk cancer, cancers that we think don't meet the definition of having aggressive features based on the grade of the cancer, their PSA level, or other characteristics. The obvious benefits of active surveillance is that they can avoid the treatment-related side effects that happen even with carefully and expertly delivered surgery, radiation, or focal therapy. But the protocol does require close monitoring of patients with PSA, periodic prostate biopsy, as well as advanced imaging like prostate MRI. This is data from a randomized trial that was conducted beginning in 1999, where about 1,500 patients were randomized to either have active monitoring of their prostate cancer or treatment with surgery or radiation therapy. And it's really striking to see that the lines are essentially indistinguishable. So the cancer-specific survival out to 10 years was about 100%, whether patients were treated or not. And this really indicates that active monitoring rather than treatment is safe and recommended for patients whose cancers are low risk. But monitoring is important because another thing we learned in this trial is that there is a risk of progression that doesn't translate to mortality right away for a subset of patients. So this difference between the patients who've been treated and not treated indicates that there is a risk of progression if we do not follow patients carefully and detect cancers that have aggressive characteristics. So I think that leads to the next question of, does treating prostate cancer improve outcome? So if active surveillance does work for some patients, why even think about doing treatment at all? And I think we have very strong evidence in support of this. This is mature evidence from a Scandinavian trial that began in the 1980s that has really exquisite follow-up, recently published out to 29 years. And this was a randomized trial of patients who had localized prostate cancer who were randomized to either having radical prostatectomy surgery or watchful waiting, which essentially meant that they would only have treatment if they developed symptoms of their disease. And so this trial enrolled patients for about 10 years, from 1989 to 1999, and were followed up until last update 2 years ago. And so over time, there really is quite an appreciable difference in the risk of death from prostate cancer between the two groups, with a substantially lower relative risk for death from prostate cancer in patients who were treated with prostatectomy versus waiting. So this really underscores the point that for patients who have clinically significant cancer, who have some evidence of aggressive features, treatment of some type to the prostate, some form of local therapy, has a substantial leads to a substantial reduction in the risk of death from prostate cancer. And at 29 years follow-up, only 8.4 men needed to be treated to avert 1 death from prostate cancer, leading to an average of about 3 years of life gained associated with treatment. And so this sort of goes back to how we classify patients. How should they be treated? And we can think of these broadly in 2 different buckets. I sort of use the term significant or insignificant. We think of those insignificant cancers as the ones we spoke about as appropriate for active surveillance. Those are the low-grade ones. And so we have a lot of characteristics that we can use to assign patients to each category. The low-risk cancers are those that are low-grade based on a biopsy, that have a low PSA level. There's not a lot of the tumor seen when we do a biopsy, and they may have a favorable genomic profile or favorable imaging, all which helps us feel confident in making that determination. And then we contrast those, which ones we think are significant, ones that are worth finding. So those are the ones that have higher Gleason score, higher PSA levels, there's more of the tumor, and they have other adverse features. And so that's really kind of the dichotomy that we're going to use today. And I'll switch gears to focus really on the significant cancers, with the understanding that we have largely moved to active surveillance uniformly for patients who have insignificant cancer. So not treating these, we do want to focus on these significant cancers where we are really poised to make the biggest difference in terms of outcomes for patients. So the first option we'll talk about is surgery. And surgery is radical prostatectomy, which refers to the complete removal of the prostate and seminal vesicles. So just kind of a refresher on prostate anatomy. The prostate sits between the bladder and the urethra. It's right in front of the rectum, and it sits really very close to nerves that are responsible for erection. So it's some very valuable real estate that we're talking about here. Most surgery for prostate removal is done robotically and exclusively at Yale. About 100% of the cases are done robotically now. And so this is a setup that involves a robotic surgical console to allow the instruments to be controlled, as well as a team of bedside surgeons helping to control which instruments go in and out. So this is a typical setup that we use at Yale. Fundamentally, what we're doing is we are taking the prostate out, which is the structure in the middle, and it sits between the bladder, which is over here, and the urethra. And these yellow structures depict the nerves that you hear so much about that are also sitting right underneath and cradling the prostate. And so these can have impacts on sexual function and something we think about. So the prostate is carefully removed from between the bladder and the urethra, leading to kind of essentially a disconnection between the two. And then the final part of the operation involves reconnecting the bladder and the urethra without the prostate in between. Okay. So the questions that often come up, what are things that we can do to preserve urinary and sexual function for patients who do have good sexual function to begin with? And a lot of it relates to surgical approach based on the appropriateness of how we approach the prostate cancer surgery based on the patient's disease. And because those nerves course right underneath the prostate, the distance that we make and how much of that nerve bundle that we preserve can have an effect on erectile function. So preservation of that lateral neurovascular bundle is important for maintaining sexual function, and we can do it for patients selectively whose tumors we do not think to be extending out. And this is sort of another depiction of it. And this is sort of what we see in real time. This is just kind of a screenshot from a recent case where we're being careful to avoid using energy, cautery around the neurovascular bundle when we're doing that dissection. What can patients expect with radical prostatectomy surgery? The surgery time on the console when we're actually doing the operation is about 3 to 4 hours. On average, patients spend 1 night in the hospital. Because of that reconstruction, a catheter is placed in the bladder for about 7 days. And most patients take about 2 to 4 weeks to recover. We advise people to avoid heavy abdominal work or lifting during that period of time. But most by the 4-week period are back up to doing the things they were doing before and back at work. There are risks of surgery. The typical risks that we talk about, bleeding, infection, incisional pain, blood clots in the legs, these are relatively rare. The long-term risks are the things we focus more about. Really the two domains that we're most sensitive to are the risk of urinary incontinence, which ranges from about 3 to 25% depending on the series. So it really depends on a lot of different factors. I think there have been a lot of improvements in the surgical approach for how we approach prostate removal with better understanding of the anatomy. And erectile dysfunction as well, which ranges based on the patient's preoperative function and our ability to perform nerve-sparing surgery. All patients who undergo prostate removal stop ejaculating. They may be able to continue their erections and orgasm function, but no more ejaculation. And of course, surgery is not a guarantee of cure, and patients are followed carefully afterwards for any signs of PSA elevation, which could indicate need for additional treatment. And these are some figures showing the potential risks to erectile function over time, which happen with both radiation and surgery. So this is showing kind of decreases over time that tend to get better. This is erectile function. So in the immediate postoperative period, even patients with a nerve-sparing surgery do have a decline in their erectile function, but gets better over time. And same with urinary function as well. There is a decline. The risk of incontinence is highest immediately after the operation, but improves by 12 and 18 months. So I'll shift gears next and talk about radiation therapy, and just want to highlight the wonderful team we have. We really have a broad range of radiation oncologists and work very closely with them when coming up with a treatment plan for patients. Many of the side effects we spoke about with external beam radiation therapy are similar to those with radical surgery, but some are a bit different because the radiation is delivered externally outside of the body to the prostate. So there are risks of gastrointestinal side effects like proctitis and enteritis. There can be flares of urinary symptoms, frequency, urgency that happens associated with the time of treatment. It generally gets better. Over time, changes to sexual function and erections, as well as risks for recurrence and secondary cancer. So what do we mean by radiation? We sort of speak about that often, but in the prostate world and at Yale, we're talking about external beam radiation therapy and something called IMRT, which is a form of intensity modulated treatment, which is basically an advanced form of 3D conformal radiation therapy that creates a dose distribution around a complex and irregular target volume. So what it's doing is it's sort of varying the amount of radiation that's given to account for differences in the structure that's being treated. And this is useful to give high doses of radiation that are needed to treat prostate cancer while reducing the risk of toxicity to the area surrounding the prostate. We're also hear a lot about something called stereotactic body radiation, which is an ultra hypofractionated radiation. So that means that they're giving fewer treatments to the prostate, each with a higher dose. And both treatments are offered at Yale. The real difference comes down to the risk level of the patient, because there's a stronger level of evidence that the ultra hypofractionated approach is safer for patients who have low and intermediate risk cancers. This is data from a trial called the HypoRTPC Trial, which was a randomized trial conducted in Europe where they compared patients who got conventional fractions, which means the number of treatments, versus the ultra hypofractionated group, the more compressed treatments. It was a non-inferiority trial, which essentially showed that the outcomes were non-inferior. So essentially equivalent prostate cancer control for patients who have intermediate risk cancers. These are not high-risk patients, but largely intermediate risk patients with a ultra hypofractionated approach. And similar effects on urinary symptoms. So that transient bump that we see in patients who are getting radiation, flare-up of urinary symptoms, similar in the conventional approach and the ultra hypofractionated approach. And then lastly, I'm going to talk about the options for focal therapy, where we're treating not the entire prostate, but just either a portion of the prostate, a zone of the prostate, or a side of the prostate. And I want to highlight one technology that is sort of newly coming available at Yale. And there are many ways to approach this, where you're essentially delivering a blade of energy to a region within the prostate where we believe the cancer to be. And this is sort of a newer approach that I wanted to talk about briefly, called TULSA Pro, which is an image-guided approach that involves a high-energy ultrasound that's targeted, and it's using real-time MRI guidance to deliver high pulses of energy to the prostate to ablate a region where the cancer is believed to be. And at the same time, so the treatment probe is put in through the urethra, so it's going right through the prostate. There's also an endorectal cooling device, which is kind of acting as a countercurrent to cool the rectum, so it's not exposed to thermal energy and protect it. This is a treatment example from one of the pivotal studies that was used to show the effect of it. And this is showing kind of density maps of both temperature and contrast of the ablation zone. And so this is how the image is planned using MRI in real time. So the patient's kind of getting the image in real time to see where the treatment should be delivered. And then the temperature can be monitored to see what areas of the prostate are being exposed to high temperatures and acute cell kill. So you can sort of see how that's happening over time, and that region of the prostate is being exposed to the transduced energy from the probe here. And you're watching it almost complete, and then finally it's sort of taken its full sweep here.
That's sped up a fair bit. It's not quite that fast.
Yes, thank you. Yes, and so not a real-time image of the actual treatment. Yes. These are some data about the disease control. This is still early data. There are not large numbers of patients who have been treated and still investigational. Early studies have shown that there about an 80% local control rate. So there are patients who do have local recurrences. About 80% were free from recurrence of a high-grade cancer, something that would require retreatment. And these are still under investigation. I'll let Preston tell you about their availability. And this is really a joint effort by Dr. Sprenkle and Dr. Ayagari from interventional radiology. So two different trials evaluating this right now. So in the interest of time, I'll end there and just make a few take-home points. The first is that really a team-based approach is key, and that really is the standard of care and something that I think we're doing extraordinarily well at Yale, collaborating with interventional radiology, radiation oncology, urology, medical oncology. So it's really a joy to be a part of that. Matching treatments to disease is paramount as well. So an understanding of the disease biology has to be used to inform the decisions we make for treatment. That being said, treatment does reduce mortality for cancers that are sufficiently aggressive, and that is the reason we do offer treatment. But part of that is making the determination of who is at risk. For those who do have compelling cancer, there are an array of options. These include improvements in surgery and radiation therapy that enhance convenience and reduce toxicity of treatment, as well as advances in focal therapy. So with that, I'll stop there and save time for questions at the end. So thank you.
Thank you.
All right, should I jump in and try to see if I can share my screen now?
Yes.
All right, wish me luck. All right, is that working?
You are on. Great.
All right. Thanks, everyone. Sorry for the delay. So Dr. Leapman did a great job of telling us sort of how we manage prostate cancer once it's been detected. This sequentially would have been better if I had gone first, but I had some technical challenges, so I apologize for that. But I'm now going to go over a little bit of sort of the prostate cancer diagnosis and also stratification of disease, and how throughout this we're trying to personalize prostate cancer diagnosis and management. So there's going to be some data, but it's largely going to be sort of the thought process of how we approach prostate cancer evaluation and screening. So let's see if I can advance this though. There we go. So disclosures, I'm a consultant for Boston Scientific and for Telix Pharmaceuticals, neither of which are relevant to my talk today. Brief overview, so I'll talk a little bit, just brief prostate cancer background, and then looking into the sort of the early detection of prostate cancer, and specifically walking briefly through the NCCN guidelines for early detection of disease, and then focusing some on risk stratification. What are the markers and techniques and biologics that we use to evaluate and stratify someone's risk, and largely to help determine which of those treatments Dr. Leapman was talking about may be most appropriate for a patient. So prostate cancer has been around and understood to be an entity since the early 1900s. At that time, men presented almost exclusively with metastatic or locally advanced disease with a life expectancy of approximately 1 to 2 years. A normal prostate is small, allows urine to pass through it, but prostate cancer can grow, cause pelvic pain, cause urinary obstruction. And it's really metastatic disease, such as the sort of the pathologic fracture visible on the right side of the screen, are the hallmark of sort of the presentation of metastatic disease. Fortunately, tremendous amount has changed over the last even 50 years, whereas in 1950, 3/4 of disease was locally extensive or metastatic. Now we see it all greater than 80% are localized with no symptoms whatsoever. The way that we do that and have that major shift is through the introduction of PSA screening. And we can see that with prostate cancer mortality specifically, it was high going into the 1990s. In the early 1990s, prostate cancer screening with PSA became prevalent in the United States. As that became more adopted, we saw a rapid and significant decline in the number of men dying from prostate cancer in the United States. In the UK, where they do not do typical prostate cancer screening, they have had some decrease, but a relatively steady level of mortality related to prostate cancer. Prostate cancer does remain a significant significant volume of the cancers detected. So it actually is 26% of the cancers affecting men are prostate cancers. However, it is only 10% of deaths related to cancer are attributable to prostate. So while it is very prevalent, only about 1 in 7 men statistically, and it's would die from prostate cancer once diagnosed, which means 6 out of 7 men with a diagnosis of prostate cancer do not die from their disease. So how do we determine who do we find? Who gets PSA screening? Who needs to be evaluated? This is a busy slide, but the NCCN guidelines try to put a lot of information into one slide, and they successfully do that here. So we're kind of going to work from the left to the right. I don't know if you guys can see my pointer, but sort of the baseline evaluation, and this is for early detection. So these are men who are interested or where you are considering evaluating someone for prostate cancer at an early stage of the disease. And it starts with a history and physical exam, so a family history, a personal history of a high-risk germline mutation. This could be BRCA2. There's a possibility of Lynch syndrome, but not necessarily. A family history. There are certain ethnic groups, and we're reevaluating this, but historically men of African ancestry are considered to be at a higher risk of having a prostate cancer. And we can start having the risk and benefit discussion with these men about whether or not screening for prostate cancer would be of benefit to them. Is this something that they are interested in? And the typical baseline screening is a PSA blood test. And we should also strongly consider a digital rectal exam. It is not required, but many on the committee feel it's very important to consider our digital rectal exam. But then who gets what? And we do age and risk stratify this based on his history and physical. So the early detection guidelines suggest starting PSA testing at around age 45. And this is for an average risk patient. And someone who does have a history, a germline mutation, or family history, you could actually start screening at an earlier age of 40. And I realize that that's younger than many of the other guidelines, but this again is for early detection. And the reason that we're doing this, and I don't want to go into this detail too much, but in men who have a PSA of less than 1, we can actually then stratify how often they should be tested for PSA or tested for prostate cancer. You can probably test it every 2 to 4 year intervals. It doesn't have to be annually. For someone with a PSA of between 1 and 3, testing between 1 and 2 years is appropriate. And for someone with PSA greater than 3 or a very suspicious DRE, you could, we'll get to that on the next slide, but you can consider further evaluation. In men who are older than 75, and very select patients in this age group, because we still, the early detection guidelines committee does agree that screening all men over 75 would be a significant problem. So we do want to tailor who we're evaluating. But PSA less than 4 versus greater than 4, really, if PSA is normal in someone over 75, they probably don't need to have a PSA tested that often and don't need to have consideration for a prostate biopsy or the next steps. But let's say we have someone with a PSA over 3 or someone over age 75 with a greater than 10-year life expectancy and they have a PSA over 4. What do we do with those men? Well, we can first off repeat the PSA. So that is something that I do routinely, and many providers who are referring patients are getting better at this, but a single elevated PSA, no matter how high it is, really merits a repeat PSA test. If a prostate exam has not been done, it should be done if someone is coming with an elevated PSA to be evaluated. This second box is where I want to kind of focus, though. Use of multiparametric MRI if available, and also considering biomarkers that can improve the specificity of screening. So what are those biomarkers? Well, there are several. The ones that are mentioned in the guidelines, the Prostate Health Index, the Select MDX for prostate cancer. So the PHI is a blood test. Select MDX is a urine test. The 4K score is a blood test. And the ExoDX prostate Intella score is a urine test. So all of these tests are acknowledged in the guidelines to be ways that we can better assess someone's risk of having prostate cancer. Please do not try to read these graphs or these area under the curve graphs, but what should be kind of clear, so the line that is straight, if you guys are not familiar with these, is sort of 50%. That's a coin toss. So a little better than a coin toss is this sort of blue line or this dotted red line or this red line, and that's PSA. So PSA is slightly better than a coin toss at predicting who may have clinically significant prostate cancer. It is better than nothing. It is better than a coin toss, but it is not great. What we see, though, is these curves that are farther to the left. So the farther to the left, you are approaching 100% specificity and sensitivity. That means that everything is right. If you're way out here in the upper left corner, that means that every test that you do is 100% accurate. We're not there with any of these tests, but as you can see, PHI and 4K similarly in this study are much better than PSA at discriminating who has a clinically significant prostate cancer. Similarly in this, looking at PHI or the select MDX or even MRI is in this one, they are moving to the left from PSA. So significantly better than PSA alone, or even PSA density. And finally, in this study, looking at the EPI score, the EPI is better than the Prostate Cancer Prevention Trial risk calculator or the ERSPC risk calculator, and definitely better than PSA. So overall, you know, these tests definitely are improving our discrimination. And I routinely will get a prostate health index test. The reason I select the PHI test, not that it's better than any of these others, but it is cheaper and it's available within Yale. We can do it within our lab at Yale. So we get a rapid reply and it's in our electronic medical record, and it's as effective as any of these other tests. So I routinely am using that test. 4K in the send out test is very easy to do and most labs will draw it. It is also very effective. The EPI test is a urine test. So they actually will ship it to the patient at home. They'll have them pee in a cup and send it back. So they've made that much easier. That is also a very reasonable test. And the select MDX test is relatively new. I don't have a lot of experience with it. It does require a prostatic massage and then a patient urinating in a cup, but it appears to have very good sensitivity and specificity, maybe even more so than at least comparable with the other of the sort of second generation PSA evaluations. Another thing mentioned in there in the guidelines is MRI. We spend a little more time on MRI because this is something that we do a lot here at Yale, and we really have specialized expertise in it. The MRI allows us to look inside the prostate, and it's a multiparametric MRI. It's not just any MRI. It combines anatomic and functional studies. So T2 and T1 weighting are anatomic studies, while diffusion weighted imaging and dynamic contrast enhancement are more functional. They tell us the density of the tissue as well as whether or not it enhances. In this evaluation here, this is our diffusion weighted imaging, our ADC image, and our T2 image. You can see sort of these lesions are representative of all these, and when compared to whole mount, it very nicely isolates the area where this cancer was identified. We grade these MRI lesions on a 5-point scale. So the Pyrad Score is able to identify and stratify these patients onto very low, low, intermediate, high, and very high risk based on of having a significant cancer based on the MRI. This was really groundbreaking. It standardized the way that these MRI were read and reported, which allowed comparison of data across institutions as well as internationally. The chair of the committee for the Pyrad's committee is actually Jeff Weinrebus, who is our radiologist here at Yale. So we are very invested in this and have been leaders in developing MRI and utilizing it. So once you have the MRI and we've been able to identify a lesion, or you have these biomarkers that suggest someone is at higher risk for having a prostate cancer, we then want to evaluate for that cancer. So the transrectal ultrasound guided biopsy is in the guidelines, or a transperineal guided biopsy with or without MRI targeting. It took a lot to get MRI here in the guidelines. I think when MRI targeting is available, it is considered the appropriate care. So how do we use this for targeting? So we do something called MRI fusion. We use the ultrasound image of the prostate, and we actually we make an outline of the prostate on the ultrasound. We have an outline of the prostate on the MRI. We actually combine those together to make a single model that utilizes the information from both of those images. And that gives us a 3D model, which is sort of here on the right of the prostate with the lesion visible inside of it. We are then able to use our ultrasound to pass needles through that area and take targeted samples of the prostate. This is especially helpful when there are lesions in the anterior side of the prostate. So the rectum is down here posteriorly. When there are cancers on the anterior side, most regular needles will not get there. We can actually see that here, where standard biopsy needles are usually away from an anterior lesion, but because we know it's there, similarly here, we can put needles through that and identify prostate cancers that otherwise would have been missed. When we look at the detection of prostate cancer using the Pyrad score, we see that it very well correlates with the detection of, as Dr. Leapman said, clinically significant prostate cancer. So the Gleason score of 7 or higher. We see clearly on low risk Pyrad's 2 lesions, a very low rate of Gleason score 7 disease, whereas in a Pyrad's 5 or high suspicion lesion, a much higher rate of clinically significant cancer being detected. Overall, when we compare a truss or ultrasound guided alone to targeted biopsy, we find that 28% of clinically significant cancers were missed by a truss biopsy alone. So we're detecting a third more significant prostate cancers than were detected by a standard ultrasound guided prostate biopsy. We see this across this is a very busy slide, but what I want you to look at is the color trends. So from left to right is the Pyrad score, and then with different patient populations, the large blocks of red are the clinically significant prostate cancer being detected. So it's much higher in patients with a Pyrad's 5 lesion. And for patients who have not had a biopsy before, we see the highest rate of clinically significant cancer being detected in those patients with a Pyrad's 5 lesion and who have not had prostate cancer before. But even in those who previously have had a prostate biopsy, so they had a biopsy, this means that the cancers were likely missed. There's still the very high rate of clinically significant cancer being detected in people with prior biopsy that was negative, which again suggests that cancer is likely missed in a truss biopsy, or can be missed in a truss biopsy. It was negative. In 2019, there was a Cochrane review of all of the published literature on MR ultrasound fusion biopsy. They looked at 18,000 studies and eventually condensed it down to 43. And they did a quantitative analysis based on 25 of those. And I'm not going to go through all the details of it. It's great. They actually have some hypothetical cases. So if you want to track this down, they work through what is the expected benefit and risk of cancers missed versus detected with biopsies based on their assessment. But their overall conclusions were that MR ultrasound fusion biopsy detects more clinically significant cancer than systematic biopsy alone. And they found that reviewing the world literature that biopsy naive patients, there was no statistically significant difference in using a targeted biopsy versus a systematic biopsy. Our data here has suggested there still is a benefit, but it may not be as great. So that gets into discussions with insurance companies. Most of them now, because patients are asking for it, will recommend a fusion biopsy. But if an insurance company or payer does not, if they won't pay for an MRI before a standard biopsy, that is not unreasonable. We sort of rail against the insurance companies, but that's actually not unreasonable because the data does not support a significant benefit. What we are preventing by doing that, though, is in those patients who have missed cancer, we are detecting it on the first biopsy rather than requiring them to have 2 biopsies because the first one was negative and their PSA continues to rise. The authors of the study argue that all men should have an MRI prior to biopsy and include combined targeted and systematic biopsies when doing biopsy, because targeted biopsy alone will miss prostate cancer. So really to kind of summarize the MR fusion biopsy part of it, so I did spend a little more time there. MR ultrasound fusion biopsy improves patient stratification. It increases the detection of clinically significant disease. We didn't really talk about negative MRI much, but it is associated with lower progression rates on follow-up, although it can still miss some clinically significant cancers. And negative MRI fusion biopsy has really a 60% lower progression rate on active surveillance, and higher grade cancers have higher rates of progression. So we really do want to follow the MRI in addition here. Once we have done the biopsy, we get the pathology information. And Dr. Leapman talked about this, but how do we then stratify these patients, right? So we're trying to assess people's risk every step of the way. We check their PSA, we get those secondary markers, we get an MRI. Does someone need to have a biopsy? What's their likelihood of having cancer? They get the biopsy, we detect cancer, we then have to grade that. And just wanted to briefly review the ISA prostate cancer grade groups, because this is how we determine who gets treatment and who doesn't, or part of it at least. So the grade groupings are 1 through 5. This replaces the Gleason score is used in addition, and the Gleason patterns. You know, the grade grouping is more intuitive. It's easier to say a 1 out of 5 is low risk and it's safe to not treat this versus someone having a 6 out of 10. So it really helps with a conversation and counseling patients. But a 1 through 5 also, without these different combinations you see in the Gleason pattern, is stratifies out very well in terms of the need for secondary therapy, and overall survival is very similar to this, but this was a nice looking graph. So you can see that for grade group 1, there's a very long period of minimal need for retreatment, whereas at grade group 5, there is a high risk of recurrence. This is very busy, but this is the NCCN risk stratification from 2021. So how does the prostate cancer, how did they determine, sorry, it's 2019, but how did they determine who gets what treatment? So the risk groups are very low, low, intermediate, high, and very high. There's favorable, intermediate, and unfavorable intermediate. And we do this based on the DRE. That's why we talk about doing a digital rectal exam, so clinical stage, and then grade group, which we just reviewed, as well as PSA value. So PSA really remains the mainstay. We then can determine, you know, based on that, what additional imaging is needed. But I just wanted to sort of show that we are doing risk stratification every step of the way to determine what is the appropriate management for these patients. Why is this important? You know, why do we want to stratify these patients, and why do we talk about different treatments? So Dr. Leapman talked about the morbidity of prostate cancer treatment. So there are side effects to surgery and there are side effects to radiation. This is really why we don't treat everyone. We want to have some patients on active surveillance. We want to have the patients who are not going to die from their prostate cancer or have significant morbidity from their prostate cancer be able to live with their prostate cancer. But knowing who that patient is key, and that is why we spend so much time in this risk stratification as we go along. You know, who is going to progress, who has worse disease. There are a variety of ways of defining who has low risk disease, who has intermediate risk disease. We can see that based on different definitions, we are accepting a certain amount of bad cancer that is being missed by the stratification. The lowest is when we stick to a truly low risk stratification, but including some intermediate risk disease, up to 20% of patients have worse cancer than we thought, depending on how we stratify these patients. Maybe we can do better. Well, one of the ways that we can try to do better than just stratifying based on PSA, clinical stage, and Gleason score is now introducing genomic testing. So this is really personalizing someone's risk and giving us a better assessment of how these patients may benefit from treatment or not. The three main tests right now are the Polaris test, the Oncotype DX test, and the Decipher. So these tests sit in this space after the screening with a PSA and DRE, after diagnosis with a biopsy. The genomic tests kind of fit in here to help make a treatment decision, active surveillance versus immediate treatment. Polaris does similar, looks at a lower score versus higher score, should be treated, maybe doesn't need treatment. And Decipher similarly puts people on a low risk of metastasis and death versus a higher risk of death and metastasis. And these scores correlate pretty well with Gleason scoring or the grade grouping, with most grade group 1 or Gleason 6 patients being in a low group. But you can see that the tail of this does extend into intermediate and high risk, whereas men with an unfavorable intermediate risk disease kind of straddles the high and intermediate groups, but there still are some men with low genomic risk disease. So we're really trying to help fine-tune these patients' risk. All three of these stratify patients based on their biochemical free survival, the risk of progression of disease, risk of adverse pathology, and some of them for the risk of metastasis. So all three of these are effective in this stratification. When looking specifically at men, if we're trying to decide if they should be on surveillance or not, with men who have low genomic scores, then the blue is those who are able to stay on surveillance. The red are those with higher genomic scores and need treatment. So we can see there's clear distribution, but all these men on surveillance, the genomic scoring is determining or helping determine who should remain on surveillance, who is safe, and who should be considered for more aggressive treatment. So in sort of summary for the genomics, I went through that relatively quickly, but the increase in genomic scores in active surveillance patients correlate with higher grade disease on repeat biopsy and if they have their prostates removed, a higher risk of adverse pathology at the time of surgery, and a higher risk of metastasis. And we use those risks to help determine who is safe to stay on surveillance and who is not. And genomics, I think, is really developing a powerful position to predict who can have adverse pathology and metastasis risk. And it's really better than grade group or PSA alone. And incorporating that in the risk stratification is going to be key moving forward. And we're really starting to do that. So the take-home points for my part of this is prostate cancer is common. PSA remains the foundation of screening and stratification. We do have new biomarkers, including MRI, blood, and urine markers to help clarify the risk of prostate cancer being present, and also then stratifies who needs treatment and who may not. I think MRI fusion biopsy is really the standard of care where it is available. Not available, obviously, trust biopsy is better than nothing, but we should be using MR fusion when it's possible. Not all cancers need treatment, and really stratifying these patients is key. Overall, the risk categories are effective in stratification, but genomic testing further personalizes someone's risk than what we can do with PSA, grade group, and digital rectal exam alone. So thank you very much, and I'm happy to, and I know Dr. Leapman is as well, to take questions if you guys have any. 5 minutes left. I was hoping to give you 5 more minutes, but thank you so much for your time.
Thank you. Thank you both. Those were great lectures. I didn't see anything come into the chat. Our last week lecture, it took a couple of minutes. And we can also unmute anybody who wants to speak directly. I'm actually curious about the genetic testing and how much of a role that's playing in when you're making decisions and advising families, and if you're finding that insurance is really covering it or not covering it, and how crucial you think it is to creating personalized treatment plans.
So yeah, I think one thing to clarify is these are genomic tests, which are testing the cancer cells for how they could behave. So it's looking at cancer signatures and how the cancer may behave. And it's slightly different than a genetic test, which is testing someone's baseline germline. So the genetic test will help you understand what you may be at risk of developing, whereas these genomic tests are really, they're looking specifically at cancer cells. So we can only do this on cancer tissue. So I do think that a genomic testing is very important. I routinely get it for almost all of my patients that have a positive biopsy. So while the NCCN guidelines currently recommend it for men with low and intermediate risk prostate cancer, it's actually been approved by the FDA for use in all men with a prostate biopsy, because we are starting to use it to tailor treatment. So even in men with high risk disease, we are tailoring the treatment that they get based on the genomic test. Insurance is covering a large part of it. There is still some pushback from some of the insurance companies, especially for people with a high deductible plan. That has been kind of challenging. And really, we do need longer term data. There is data emerging now that does show that these tests do help. They help stratify patients, but they help with treatment decisions. So in men who have had prostate cancer treated, it does definitely help determine who should, and the timing of radiation treatment in the salvage setting. In terms of men, whether or not they should get treated based on their biopsy, it's we're still figuring out exactly. It changes our pattern of practice, so it changes who we put on surveillance and who we treat. Whether or not that's associated with long-term survival, where those studies are still being done. I don't know if Dr. Leapman has any comments on that, but I'm excited about it. I think we're still early in the kind of learning curve of working with it, though.
Yeah, I would agree with that we're still sort of in the information gathering phase, and I think that we're coming from a perspective where we've sort of been in the dark on what risk is and how do we manage that, how do we make decisions with it. So I still think we're very much in the infancy of doing personalization. So I think we will be getting more evidence from trials that are underway that look at how exactly the use of genomic testing is affecting decision making and if it affects outcomes more importantly.
Are you seeing in the chat asking about the 2021 guidelines?
Yeah, I was just texting a response, but they should be available on the NCCN website. The early detection guidelines are for 2021 are available. I didn't check the prostate cancer treatment, so it's actually interesting. If you go for cancer management, the prostate cancer ones are there, but it's actually in a separate section for early diagnosis, where you would find the early diagnosis guidelines. But I believe that they should be available, and registration is free. So if you register, you can then log in and access them. I don't believe they differ too substantially from the AUA guidelines. But I actually haven't checked the AUA guidelines recently. I typically use the NCCN. So George asked about the active surveillance protocol now. It hasn't changed too dramatically yet. I think the current NCCN guidelines suggest a biopsy every 1 to 2 years for patients with low-grade disease. I think it does vary a little bit by provider. I would like to standardize that. Dr. Leapman and I will probably talk about this some more, as I know we're trying to kind of standardize the approach. But in general, still a PSA every 6 months is definitely, everyone should be doing that. An MRI and biopsy, I believe at 12 months is appropriate. After that, we can potentially space it out based on the genomic testing. So that's the one thing that I'm kind of holding on to right now, is a 12-month biopsy as an initial repeat fusion biopsy. We may be able to space that out more as we get more information. We just have seen a couple patients where even with a fusion biopsy, they've had an upgrading at 1 year, and that upgrade risk seems to be less after that second biopsy. But we definitely am using the genomic testing for men who have low-grade disease and are low risk. If they have a low genomic score, I will very readily push them out to 24 months for repeat biopsies. I feel very comfortable with that, as long as we're continuing to follow our PSA.
Okay, I think that's it, and we're definitely on the hour. Thank you both very much for speaking tonight. We appreciate it. This will all be archived for viewing at a later date as well. And we look forward to next week. So thank you both very much. Have a good evening.
Thanks, Trace.